Welcome, everybody, to evaluation of localized prostate cancer and making common sense logical treatment decisions with Dr. Timothy Wilson, MD. He is professor and chair of the Department of Urology and Urologic Oncology and director of Urologic Oncology Research. I'm going to tell you about his very interesting areas of research over at what's called Providence St. John Cancer Institute in Santa Monica, California, formerly the John Way Cancer Institute, and that's in Santa Monica, California.
Before introducing our speaker, a quick word about the Prostate Forum of Orange County. The forum is a group of men who themselves are dealing with prostate cancer and who want to support anyone else who is dealing with the disease. We do this by offering information, education and hope through our website, prostateforum.org, and through monthly support group meetings and presentations by experts. There are 2 online support meetings each month. The first, mainly for those newly diagnosed with prostate cancer, meets on the 2nd Tuesday of every month, and another meets on the 4th Tuesday of each month, mostly focused on advanced and recurrent prostate cancer. Both meetings are free and open to anyone affected by prostate cancer. In addition to these meetings, support groups, we also offer on most months talks by experts in the diagnosis and treatment of prostate cancer, just like tonight's presentation. Topics from these experts range from diagnosis to active surveillance to radiation, surgery, side effects, genetics, and other medical advances. You can learn about upcoming presentations at prostateforum.org/speakers or view previous presentations at prostateforum.org/presentations or on our YouTube channel at youtube.com/@prostateforumoc. To take advantage of these resources, we encourage you to sign up to receive announcements of meetings, presentations, and newsletters. And when you're ready, please consider helping us help others who are dealing with cancer. We're all volunteers, and we invite you to volunteer some of your time and expertise with organization, coordination, marketing, website maintenance, whatever you can. Whatever you can give will really help. And even though our volunteers are not paid, our expenses are very real. Your donations will help us to continue providing education, information, and hope to men with prostate cancer and their families and friends. With that, let's turn to tonight's speaker.
Dr. Wilson was chief of urologic oncology at City of Hope in Duarte, California. He is now a director of research at Santa Monica at St. John's. He's an expert in a wide range of urologic surgical procedures for men, not just those involving prostate cancer. Is it just men, doctor, or do you also work with women as well?
No, so women, women with bladder cancer, of course, and I don't do a lot of kidney cancer anymore, but with some forms of kidney cancer and that sort of thing. Yeah.
Very exciting. He's committed to researching surgical techniques that improve the functional outcomes for men following robot-assisted surgery.
All right. So it's a pleasure to be here. Of course, Dr. Metzger is the one that invited me, and although I can't, it's always a little bit odd when we're doing one of these Zoom presentations, you can't see the audience. As Chuck would tell you, I'm a little bit of a interactive guy. So I have more slides than I need, and I hope I haven't made this too lengthy, and I hope we have some time for questions. So I wanted to talk to you about some of the changes that have happened with prostate cancer over the years and where we are now with prostate cancer, and also just put to rest some of the controversies about prostate cancer and some of my biases about how we should manage it. I guess. Okay, so some misconceptions about prostate cancer. That, number one, that it only affects old men. Indeed, I've treated men in their 30s with prostate cancer. That it doesn't need to be treated. In other words, that most men will die from natural causes and not from prostate cancer. But indeed, prostate cancer is very serious in many men and needs treatment. It's up to experts, of course, like me, to help guys decide who needs to be treated and who doesn't, and of course how they should be treated. Misconceptions about screening offering no benefit. I'll try to clarify that. That men will be permanently incontinent after treatment, like surgery. Not true, and that there's no sex life after treatment. So we'll talk a little bit about the incidence and significance of prostate cancer as we sit here in 2023, where we are now with screening and diagnosis, and of course about the management. I think most of the guys that are on the Zoom visit tonight know where the prostate sits. You can see in this cutaway cartoon of the male penis. My former associate at City of Hope, Dr. Kawachi, would respond when someone asked him, "Doctor, where's my prostate?" He would say, "Well, it sits just above the penis, behind the pubic bone." And then he would say, "Most men are able to find their penis." So this is the prostate here, sitting just above the penis. What does PSA do? So PSA primarily functions to liquefy semen to help conception. It's an indicator of prostate problems if it's elevated, but not specific for prostate cancer. It's elevated with enlarged prostates, prostatitis, and of course prostate cancer. And just by way of how we got in trouble with PSA, it was first described and discovered, I think, in Japan, the Japanese were the first to describe PSA. And you can see where we were in the when PSA was discovered, just in the late 80s. Of all men that were diagnosed with prostate cancer at that time, a full 25% went on to die from prostate cancer within 5 years. But by 2002, after only screening for prostate cancer on a routine basis for a little bit more than a decade, less than 1% of men that were diagnosed with prostate cancer were dying from prostate cancer. So we made some great strides forward, and we shouldn't forget that that's in the context of prostate cancer being the most common cancer in men and the second leading cause of cancer death in men, as I'm sure most of you undoubtedly know. And in fact, it's the most frequently diagnosed cancer in Europe, North America, South America, and Australia. It's the leading cause of death from all causes in the country of Sweden. Second leading cause of cancer death in men in the USA. Third leading cause of cancer death in Europe. Just under 400,000 cases in Europe per year, and 90,000 European deaths per year. So prostate cancer is common. And as I said, it's the second leading cause of cancer death in men, so it's extremely important. On the other hand, many prostate cancers, in fact, do not need treatment, as I'm sure most of you are aware of, or active surveillance is a common modality of management. However, we shouldn't be misled. If men do get treatment, there's really no free lunch in that regard. Any intervention for prostate cancer treatment and management can have potential side effects. Risk factors for prostate cancer include age. As it is true that as we age and get above the age of 50, the incidence of prostate cancer continues to increase. African American men have the highest incidence, followed by men of Northern European descent, followed by Latin American men, and then Asians. So geography is a factor. Typically North American, Northern Hemisphere. Genetics play a part. Diet, we think that Western diets, of course, are risk factors for prostate cancer. Obesity, chemical exposure. We know that firefighters have an increased risk of prostate cancer, and Vietnam War vets that were exposed to Agent Orange. Chronic prostatitis through a phenomenon or a process regarded as chronic oxidative stress can lead to a higher incidence of prostate cancer. So screening really makes sense because prostate cancer is extremely common, and screening is relatively simple and inexpensive, just simply requiring an examination of the prostate to look for nodules or something suspicious, and a PSA. But indeed, we know it's more complicated than that. But despite the fact that we can find it early, and I showed you data showing that once we started screening in the 1990s, the U.S. Health Task Force in 2008 recommended against screening for prostate cancer in men aged 75 years and older. But interestingly, they went on then in 2012 to recommend against prostate cancer screening in all men in the United States. This is despite the fact that this graph looks at the incidence of fatal prostate cancer. And you can see in the left here in this graph A with the rates of fatal prostate cancer in all men of all ages, that beginning in about 1990, when we began screening for prostate cancer, we began to see a precipitous decrease in the incidence of fatal prostate cancer. In other words, we were finding it early and we were curing it. This was mainly, if you look in panel B here, mainly in men that were above the age of 60, because that's where screening was primarily concentrated in men above the age of 50. But with that recommendation, there was even in that short period of time, this is published by a former fellow of mine named Jim Hu in JAMA 2016, in men above the age of 75, even within 8 years, we were seeing an increase in the incidence of metastatic prostate cancer. And if you look at the same publication data here in men less than 75, the percent of men with metastatic prostate cancer, or then presumably going on to be lethal, nearly doubled in men less than 75, and as well as men 75 and older, it was even a higher increase of men that were diagnosed with metastatic prostate cancer because we were becoming more lax and not screening for prostate cancer. This is also despite the fact that what was known as the ERSPC, a study that looked at screening in 162,500 men over a 13-year period of time, showed that by screening men in a regular basis and with a precise methodology, you would increase the number of men diagnosed with prostate cancer by 17%, and in fact decrease the death rate by 35%. So there was with screening on a regular basis, you can decrease the death rate by 35% and also significantly decrease the risk of men getting metastatic prostate cancer. Now, however, as I said earlier, the problem with screening, as we did in the United States and around the world, is that we were finding all these men with prostate cancer, but in fact, probably half of them did not need treatment. But we didn't know that then. And this is a graph of the increased number of radical prostatectomies. You can see in the gold here, the top little number here. Are you able to see my cursor, my mouse?
Yes.
Thank you. So what happened here is that my associate at the time, a guy that I worked with for over 20 years, Mark Kawachi, and I were seeing many men with prostate cancer as we were an early adopter of robotic prostatectomy. And by 2009 and 10, we were doing about 1,000 radical prostatectomies a year. But it turns out that probably half of those guys probably didn't actually need treatment. So we could cure them, but obviously we were operating on men unnecessarily. So today, as we sit here now, screening for prostate cancer, we should do it, and we should not assume that prostate cancer is not an aggressive disease, but we should be much smarter in how we do it. So we still recommend, I think, PSA and physical examination annually. There is some data that in some men with very low PSAs that you may be able to stretch out the PSA to every 2 years, but my bias is still in getting PSAs annually. But through a shared decision-making process between the urologist and the patient, or the primary care physician and the patient, as to whether or not the patient wants to do that, wants to find out, it's like, should we do it? And we should, if we're going to screen for prostate cancer, we should begin, I think it's still at age 50 and even at age 40 if men have a strong family history of prostate cancer and 2 to first-degree relatives, or if they have a genetic risk like the BRCA positive gene. But the goal, of course, is to avoid unnecessary biopsies. And if we do it in a smart way, we can do that by using adjunctive tests that help perfect PSA and also MRI of the prostate. So what we do is we check a PSA, and we examine the prostate. If the PSA is abnormal for the age of the gentleman or rising at an abnormal rate, then we'll oftentimes at that point do one of these adjunctive tests, such as what's called a blood test called 4K, a urine test called Select MDX, another urine test. These are competitors that try to distinguish whether or not men are at increased risk of having prostate cancer. And in some ways, MRI of the prostate has become another screening tool for prostate cancer in order to see if there's any abnormalities on the MRI that appear to be consistent with higher risk or more aggressive prostate cancer. And then another standard is to use the MRI as a guide for the biopsy. So although I still see a lot of men that are undergoing biopsy that haven't had an MRI, and it was difficult to get insurance companies to approve MRIs as recently as 2015, 2016. Today, it's really not. For an elevated PSA, an abnormal feeling prostate, a rising PSA, or any of these abnormal tests like 4K, Select MDX, ExoDX, usually we can get MRIs approved, and they're routinely covered by Medicare. So, and the biopsy, we think, I recommend that if men are going to have the, again, if they've had the MRI and there's an abnormality or what we call a target, a region that looks like it's suspicious for prostate cancer, then we do the biopsies with what is called MRI fusion. So this is where we are digitally matching with software the MRI and the way it looks with the ultrasound in real time. So we can make sure that we're accurately biopsying the target that's seen. And this can be done either through a transrectal biopsy that I'll describe in a second, that is the most common way, or a transperineal biopsy that I'll also describe. And the standard, I think, agreed upon by international societies like the AUA would be to biopsy the target, the region of interest, the area that looks abnormal on the MRI, but we would recommend biopsying the rest of the prostate as well. And this is so that we can truly map out the prostate. So this is a cartoon of a gentleman on his back with his legs up. You can see the penis here, the scrotum, the bladder. The prostate's here underneath the pubic bone, beneath the penis. The probe is in the rectum, and the needle goes, you can see in this cutaway, the needle going through the rectal wall into the prostate, into the back of the prostate here. So the rationale, and this was the most common way when beginning in the early 1990s, when transrectal ultrasound became available, became the most common way, and has been up until just recently, to biopsy prostates. And that made sense before MRI, and made sense before we knew more about where prostate cancers are located in the prostate, because the periphery and the back of the prostate, when I say the back, I mean the posterior part, the part that's closest to the rectum, is where most prostate cancers are located. However, because they aren't all located there, a TRUSP, or a transrectal ultrasound guided prostate biopsy, that's TRUSP, will have a false negative rate. In other words, miss the cancer about 20% of the time. And furthermore, it can't accurately or sample or biopsy the top of the prostate, the anterior region, the part that's closest to the pubic bone. So it is true, as I said earlier, that multiparametric MRI, the standard way to do MRIs of the prostate, improves diagnostic accuracy. However, MRIs will also, they'll miss prostate cancer about 15% of the time. And that's indeed why we need to do a real-time biopsy and biopsy the target with this fusion technology that I'm advocating and arguing for, as well as a systematic biopsy. That means biopsying the rest of the prostate kind of in the old-fashioned way as well, so that we completely understand where the cancer is, if it exists. We also know if it's not, not only is it isolated just to one spot, but we know the details of that cancer, how much of it there is, and the aggressiveness level. So the goal is to map the entire prostate. Now, transperineal biopsy is done through that area of skin underneath the scrotum, between the scrotum and the anus, referred to in the colloquial as the taint. So the perineum is that skin again between the scrotum and the anus, and that's because we can, and I'll show you a picture of that in a second of how it's done, but it's this is because there's less infection is one reason to do it, because we're not going through the rectal wall, and so there's less risk of seeding the prostate with bacteria from the rectum. We can better sample the top or the anterior part of the prostate while at the same time accurately biopsying the bottom or the posterior part. We can also do this with MRI fusion, so we can match up the ultrasound with the MRI. We can do it under local anesthetic if you choose to, although with the transperineal biopsy, since we're going through the skin and it's different and the legs have to be up, kind of like a woman would have a pelvic exam, and it's difficult for men. It takes about a half an hour. So I prefer to do a transperineal biopsy while men are asleep, as opposed to a local anesthetic. And it's a little bit more time consuming. A transrectal biopsy, whether with fusion or not, will take about 15 minutes. A transperineal biopsy takes about 30 to 45, at least in my hands. So this is how a transperineal biopsy is set up. You can see the cartoon with the penis here, testicles here, the prostate's here, the ultrasound's in the rectum, the needle's coming through the skin, the perineum, and here it's putting in a spacer prior to this little blue dot represents a protector, what's called a spacer between the prostate and the rectum to help protect the rectum if the patient's going to have radiation as a treatment. But you can see that we can easily access, and with this technique, the top and the bottom, and actually on each side of the prostate as well, accurately without going through the rectum. So this is, I'll explain this. This is an MRI with a cross section. So in this image, the pubic bone sits to the top here. This is the rectum, and this is the prostate. The central part of this is what's referred to as the BPH, the part that can block up the bladder that causes men to urinate, with a poor stream and more frequently. This diamond-shaped region in the peripheral zone. This peripheral zone normally on this particular kind of MRI image should look bright. You can see this kind of wedge-shaped section here, this diamond-shaped, not diamond, but pyramid-shaped lesion here, which looked abnormal, what's called T2, whereas over here, with enhancement, it also shows bright. So that's a sign that there's probably about a 60 to 70% chance that there's prostate cancer in that spot. So you can see with a transrectal biopsy, we can easily hit this peripheral, sits right above the rectum, easy to target, easy to hit. Whereas here's now a panel of MRIs on the same patient, a different patient than the last one, but all of these panels, these three panels of MRI are on the same patient. And you can see on this T2 image here, here's the rectum, here's the prostate. The white arrow is showing a dark area towards the top part of the prostate, which is dark also on what's called the ADC map, and bright on what's called the DCE. So these are also, this is a large lesion, has about an 80% chance of having prostate cancer. But if I didn't have an MRI to show me where this is, and I did a transrectal biopsy from here, poking up into this peripheral zone. This isn't even in the peripheral zone. I would miss this cancer, and it would go undiagnosed. And indeed, this gentleman ended up having what's called a high intermediate risk prostate cancer in this area. So for some men, we want to do, depending on what the MRI shows. That's why the MRI, I think, is so important before the biopsy. Because number one, we want to know if there's something that needs to be biopsied. And number two, of course, where it is, so we can biopsy it more accurately. Now, for those of you that have prostate cancer, you've heard about this thing called the Gleason's score, the Gleason's grading. It's an older system. It was developed even in the youth of Dr. Metzger that long ago, and in my youth as well. So in the late 1960s, early 1970s, a guy named Gleason, who was a pathologist from Minnesota, developed this system for looking at prostate cancer under the microscope. This is a drawing or a cartoon, a schematic of how pathologists look at these cells under the microscope, graded 1 through 5 at the time. So Gleason himself called 5 Gleason's grades, and it's confusing. Now, he did it on a scale of 1 to 5, as shown on this black panel here, 1, 2, 3, 4, 5, 1 being least aggressive, 5 being most aggressive. Now, about 15, 20 years ago, we figured out that grades 1 and 2 aren't really cancer. So these days, we only have grades 3, 4, and 5. And to simplify it some, now we understand the aggressiveness of prostate cancer in what's referred to as Gleason grade groups. Grade group 1 would be all if it were just Gleason's grade group 3. Grade group 2 would be predominantly grade 3 with less than 50% grade 4. Grade group 3, primarily grade 4 with less grade 3. And grade group 4, anything that equals 8 adds to 8, because it's often a combination. And grade 5 is Gleason's score 9 or 10. So we would say generally that anyone with any grade group 3, 4, or 5, we generally say, depending on multiple factors, I'll discuss these in a sentence, that those guys need treatment. Whereas guys with grade groups 1 and 2 may not. And we'll talk about that. It depends on really how much grade 4 there is. We certainly have large studies showing that grade group 1 is safe to monitor, and many patients with grade group 3+4 as well, or a grade group 2. So when we do the biopsy, then we end up with a mapping of the prostate. This is an older slide, but it demonstrates that we might have a biopsies just in this case on the left. Now these little ears up here on these drawings here represent the prostate in 3 different men. The ears represent what are called the seminal vesicles, the glands that sit up above the prostate underneath the bladder, but they're attached to the prostate. They make the bulk of semen. Now this gentleman has up toward on the base is the part of the prostate up towards the bladder. The apex is the tip out towards the penis. Now in this gentleman on the left base and mid, he's got 2 of 14 cores. You only see 12 here. They've biopsied 2 other areas as well that aren't shown here. 2 cores, small volume prostate cancer. Whereas this gentleman, he's got Gleason's grade group, looks like 4 and 5, but just in one limited area towards the apex and on the left mid to apex here. This gentleman up here has Gleason's higher grade cancer on both sides of the prostate. Gleason score 7, 10. So this is grade group 3 and 5. Gleason's grade group 1 here. So at any rate, he's got bilateral disease. And so we would say he needs his whole prostate treated one way or another. This gentleman could be a candidate for focal therapy, just treating that part of the prostate. This gentleman may well be a candidate for active surveillance and careful monitoring, depending on some other details I'll describe in a second. So when we counsel men with prostate cancer and talk about making common sense decisions, we need to know all the details. the Gleason's grade and the group, as I've described, incredibly important. The stage, meaning, is it confined to the prostate? Can I feel it with the finger? Part of the decision-making process. So, and the volume, of number of biopsies that are positive, the location of those biopsies is important, and the MRI findings. Also, something I haven't mentioned here that's relatively new, a newer PET scan called PSMA PET can also, as part of the current staging, compared to older staging, which was done with a CT scan and a bone scan. And a CT scan and a bone scan for men, as trying to find out if the cancer has spread or not, is really extremely poor and inaccurate way of finding prostate cancer outside the prostate. So this newer PSMA PET scan is a better way of it's not perfect, but it's the best way we have of trying to find out if there's prostate cancer cells outside the prostate. But now, also when we're counseling men with prostate cancer, we want to discuss what their symptoms are. You know, meaning their urinary symptoms primarily. Are they getting up at night? Do they have a slow stream? How bothered are they with their symptoms? Because how we treat the cancer, if it needs treatment, is going to may be impacted by what those symptoms are before there is any treatment. The size of the prostate will make a difference, and also, probably most importantly, the life expectancy and the overall health of the patient. So oftentimes, there's a ton of information on the web about prostate cancer. This is a biased book written by the former chair of urology, Pat Walsh, from Johns Hopkins. Dr. Walsh is still alive and doing well, still lecturing. He's the guy who first described nerve-sparing prostatectomy, sparing these nerves that are responsible for erections and also helping with bladder control following prostatectomy. I think it's a good start for men that are diagnosed with prostate cancer to look at this. I think it's in the 12th edition. You can get it on Amazon Prime, and I think it's a great way for men to get introduced if they've been recently diagnosed with prostate cancer, you know, what the options are. But again, it's biased. It's from a surgeon's perspective, and Dr. Walsh never did robotic prostatectomy. So when we manage localized prostate cancer, we're looking at multiple different options. So active surveillance, focal therapy. In other words, focal therapy refers to treating just one part of the prostate with something like freezing it with cryosurgery, HIFU, high intensity focused ultrasound. Or there's a newer treatment that's it's an older technology. It's been around for 10 or 15 years. It's also it's called NanoKnife. I'll talk about it a little bit tonight, but it's with voltage directed into the prostate with needles. It's referred to as irreversible electroporation. Of course, there's radiation options such as external beam radiation, something called tomotherapy, brachytherapy seeds. So, and radiation is often combined, but not always, with hormone therapy. And there's surgery. So this gets confusing. There's a lot of options. And of course, you know, in the United States, this is a little bit of a political comment because of the way healthcare is in the United States. You know, doctors get paid for things they do to patients, not for not doing something. So we're all incentivized to do something. You know, so as a result, here, at least at the St. John's Cancer Clinic, we offer all these options. We offer, you know, active surveillance. We offer, we used to offer focal cryo, but our guy doing that left, Mark Kelly. So we have HIFU that we do here. We're starting a program with NanoKnife, which I think competes with cryosurgery. We offer all kinds of radiation options, and of course, surgery, essentially robotic prostatectomy. So we try to pick the right treatment for the right, you know, to fit with the right patient and the right details. I'll come back to this, which you've already seen. Again, this gentleman may qualify for active surveillance. This gentleman for focal therapy. This gentleman whole gland therapy would mean either radiation or surgery. So, again, to reiterate, prostate cancer is common. It's fatal if it's aggressive and diagnosed too late. Screening is safe and can save lives. Over-treatment can be avoided with proper testing and evaluation. Treatment can be appropriately delivered to those that need it and tailored to the individual. And I'm looking for, so we still have a little bit of time here. I'll keep going. So speaking of active surveillance, so probably a lot of you, this is kind of the most recent data and up-to-date data on active surveillance, and it's called the PROTECT trial, recently published in New England Journal of Medicine last spring. And it randomized about, I think, 500 to 600 men in each group, surgery versus radiation versus active surveillance. And it was, men were either low risk, Gleason's grade group 1, or many with Gleason's grade group 2, Gleason's grades 3+4, but lesser grade 4. So matched patients, 15-year follow-up. This is prostate cancer specific survival equivalent. And this is men that developed metastasis during, they didn't die from prostate cancer necessarily, but they developed spread of prostate cancer. This dotted line down here, there was a higher incidence of metastasis in men that went on active surveillance. Now understand that in this study, the men on the active surveillance protocol, or arm, I should say, had an option of converting to either radiation or treatment. And about half of them, in fact, I think it was 60%, during the monitoring were found to have, because they were on active surveillance, which means they were having PSAs about every 3 to 6 months and an MRI or a repeat biopsy once a year. And so if they progressed, then they would go on to get treatment. So this is not only active surveillance or only non-treatment. These men were on active surveillance initially and then went on to get treatment if they needed it. But what it does tell us is that active surveillance is extremely safe for those men to qualify. Now, we would like to know who those men are ahead of time. How can we tell in someone with Gleason's grade group 1 or 2 who's going to progress and who's going to need treatment? So there's some genetic testing we can do on the cancers themselves to see who's likely. It's not really a yes or no, but who's likely to require treatment. For instance, the Cipher test on a biopsy in a patient that had Gleason's grade group 2, so primarily grade 3 with some grade 4, Gleason's grade group 2, his Decipher test was low, and so we thought he was an adequate candidate for active surveillance. Whereas this gentleman here had a higher Decipher score. In fact, he had Gleason's grade group 1, 3+3, but it looked like he was going to be in a more aggressive group. So we thought that he probably wasn't a good candidate for active surveillance, and he probably needed some sort of therapy, not necessarily radical therapy, maybe HIFU, maybe focal cryo. So again, that doesn't mean we need, but we thought that he needed some sort of more aggressive therapy other than just monitoring. So let's talk about that a little bit. Focal therapy, and this has to do with treating just part of the prostate. It's kind of analogous to a lumpectomy in breast cancer treatment. We're not actually taking out that part of the prostate, but we're ablating it by either freezing it, treating it with heat, like what's referred to as HIFU, high intensity focused ultrasound, or this newer technology that I think will compete and ablate tissue like cryo, called NanoKnife. It uses voltage, electrical voltage, administered between needles to eradicate prostate cancer, but only so. It's done kind of like this. I'm not sure this is the best cartoon. This recommends this represents the rectum with the probe in the rectum. This is the prostate. This disc up here is the pubic bone. These are some needles coming through the perineum, like a transperineal biopsy. This is the prostate. This is the bladder. And these are cryoprobes that are going to be put into the center of the lesion. So for a guy to currently be recommended for focal therapy, generally speaking, they should have relatively small volume cancer, not in the tip of the prostate for cryo or for HIFU, and it should be in an area that we see on the MRI, so we can target the therapy in that spot, and the rest of the prostate should not have any aggressive cancer in it. Now, we can treat more than one spot with these lesions, a quarter of the prostate, half of the prostate. It's generally recommended that these therapies that are delivering energy to the prostate not treat the whole gland, because then the risk of side effects increases significantly. And it's usually recommended for Gleason scores 4+3, which is Gleason's grade group 3 or less. The downside is that it's not without potential side effects. Men must continue to be monitored like they're on active surveillance, because we still have untreated prostate. Furthermore, you can have failure in the area that has been treated, so we have to do future biopsies. This will cause some men anxiety. And with most of these therapies, except NanoKnife, and again, I'm just learning about NanoKnife myself, you can't treat the apex of the urethra because it causes scarring in the urethra, which is problematic. Whereas NanoKnife seems in the hundreds of patients, almost 1,000 patients that have been treated with NanoKnife, at the urethra and the apex, it doesn't seem to cause any scarring there. But more to come on that in the future. And the failure rate is probably 20 to 50%, depending on the modality. So that, in other words, future treatment can certainly be in the future, can be possible or necessary. And having previous focal therapy can affect the way the prostate is affected by inflammation surrounding it, which can make surgery, if that would be the next treatment option, it can make it a little bit more difficult and risky. In fact, here's a long-term study on HIFU, which is probably the most popular kind of focal therapy currently used is HIFU. We have a device here called Focal One. It was developed in France. We've used it here for about 5 years. I don't do it, but my colleagues, Dr. Linehan and Dr. Movasagi, do focal HIFU. And it's best in the bottom of the prostate, the peripheral zone of the prostate, the back of it, toward on the rectal side. It's done robotically under MRI guidance. Men are asleep under an anesthetic, and we treat that area of the prostate. But in this study, where they were doing hemiablation by Roland van Belthoven, who's from Belgium, they treated men with HIFU and found
Join the meeting.
And found that about, as you can see, about 25%, even in the low risk category, recurred based on the what's called the Phoenix criteria for another PSA recurrence, and about more than 50% recurred if they were intermediate risk. So it won't. It depends. This is a little bit older technology than is currently available, but this is about 7 to 10 year follow-up. And it's not without risk. Again, nothing comes without some risk. In these men, about 18% had a worsening of their lower urinary tract symptoms. In other words, trouble getting the urine out. About 20% developed erectile dysfunction, and about 6% had prolonged incontinence. Now, this is a hard slide to see, I think, but this looks at different kinds of focal therapy. Over here in the far left in the dark blue, HIFU with also a TURP at the same time, a TURP, a roto-rooter, laser, focal cryo, focal brachytherapy, putting radioactive seeds in the prostate, and IRE or NanoKnife. And there's anywhere from 8 to 27 studies. You can see a varying number of 75, 26, 89 patients. So not a large number of patients. Follow-up is around 2 years. The number of failures in the area that was treated, about 15% with HIFU, about 17% with laser, 15% with cryo, about 12% with brachy, about 7% with NanoKnife or IRE. Serious adverse events, serious side effects, relatively low, less than 10% generally. Men that were incontinent afterwards, very low, only 5% with HIFU, 0 with laser. Trouble with laser is that it's too focal. It treats only that one little spot, and it takes forever to do, and you can only treat. So it's a difficult logistically. Cryosurgery, a little bit higher, anywhere from around 10 to 15% of men had incontinence. So none of the men with focal brachytherapy, none of the men with nanoknife, erectile dysfunction, 20% with HIFU, not reported with laser, about 30% with cryo, 0 to 50% with the seeds, 7% with nanoknife. And also the cool thing about these kinds of therapies, if men have had previous radiation, this is one of the problems with treating men with radiation is the primary treatment for prostate cancer is that if it recurs, it's a difficult problem to manage. You can take it out. That's called a salvage radical prostatectomy. You can freeze the prostate. You can use HIFU on it. You can use nanoknife. You can use high dose rate seeds or low dose rate. So basically, the trouble is that the 5-year recurrence-free survivals are only about, they're about 60%, 50 to 60%. In other words, meaning that the cancer has actually been cured by these modality, and the side effects are relatively high with surgery, cryo, HIFU, but acceptable with nanoknife, high dose rate seeds, low dose rate radiation. Those kinds of things can be used, and the severe side effects from in terms of GI side effects, the bowel side effects are quite low. So we've talked about active surveillance, and that's a reasonable thing to do with low risk disease, low volume disease. Focal therapy, reasonable to consider if it's intermediate risk, maybe, or limited high risk, just to one spot of the prostate. Again, unclear as to which one of those modalities is best. Now let's get down a little bit to what's called whole gland therapy. Now, this means, are we going to treat the prostate with radiation or to surgery? Now, I'm a surgeon. I'm biased in favor of surgery, but this is a paper that was reported a few years ago, 2015, that was a worldwide, what's called a systematic review of surgery versus radiation, put together by a group of experts, not just urologists, looking at comparing radiation to surgery. They looked at randomized controlled trials that had follow-up greater than 5 years. They excluded just non-peer reviewed or editorials, commentaries, bad studies. They included men of any age treated with non-metastatic localized prostate cancer. They included men that had radiation of the most commonly utilized methods of external beam radiation, something called IMRT, and brachytherapy, putting seeds in the prostate. And they only studies that were reporting multivariate analyses. And so I'm not trying to throw any science at you, but these curves, and these are called forest plots. Up here on the top, so they compared multiple studies that looked at either surgery or radiation, or compared the two, and with the criteria I described. And in all these studies that they thought were the best published at that time, all of them favored surgery in terms of overall mortality. In other words, men that had surgery lived the longest and dying from any cause. However, by the same token, men that recurred of cancer in all these studies, only one showed that radiation was better. I'm not saying that radiation doesn't work. I'm only saying that this particular study, multivariate analysis, showed that surgery appeared to be better in terms of overall mortality and in actual cancer recurrence. So again, I'm biased also in favor of surgery for those men that qualify. Now you may have heard that surgery is worse in terms of causing incontinence or erectile dysfunction, but this particular study was interesting because it didn't look at those kinds of complications. It comes from Canada, where they have socialized medicine, of course, but they can better review their data, and they compared men that had either surgery or radiation in terms of, and it was about 16,000 men in each group treated over the same period of time. Now, the men that had surgery were younger compared to men that had radiation. The number of men in surgery that were hospitalized within 5 years compared to men that had radiation, it was 10 times higher, almost 11 times higher if they'd had radiation. Men that required a future rectal or anal procedure, the one represents the same as a control group they looked at. It wasn't any worse than those men that hadn't had surgery or didn't have prostate cancer. Whereas with radiation, it was nearly 3 times higher for any kind of rectal or anal procedure, 2 times higher for a second cancer of the rectum, a cancer of the bladder or pelvic bones. The same thing with any kind of surgical open procedure. Men that had had previous prostatectomy, same risk as those men who hadn't had anything done, compared to a 3 to 4 times higher risk of having surgery if men had had previous radiation. So furthermore, this looks at the likelihood that a different study published in a radiation oncology journal does show, this is comparing seeds in the yellow, external beam radiation in the yellow graph here at baseline time of treatment. They all start the same. The fuchsia is seeds, the green is surgery. Surgery and seeds drop initially, but then everybody recovers. And at 12 months, the quality of life scores is what they're looking at. Men are doing about the same. I'm going to kind of, because of time, I'm just going to say that, the robotic surgery called RARP certainly shows that that's the current state of the art, but it is surgeon dependent, and it depended on the techniques the surgeon uses. And the advantages of surgery, as I see it, is that and this is again my bias, it's a little bit less expensive than radiation. It's better for staging. It relieves blockage because it gets the prostate out of the way of the bladder, offers the best cure rates, I think. PSA also becomes a more meaningful test because it should be 0 after surgery. It's not 0 after radiation. It allows us to make more rational decisions about adjuvant therapy. In other words, if the PSA is 0, we know there's no evidence of recurrent cancer. But if the PSA becomes detectable and is rising, we know that's been heavily studied. We know that those men, some of those men will require treatment. And furthermore, that salvage therapy, so giving treatment after what was ever done first, is easier if men have had either focal therapy or the whole prostate out, as opposed to radiation, which causes not just damage to the prostate, but damage to neighboring organs as well. So again, that's my bias against radiation. But I do think radiation, as you've learned, I'm sure from other speakers, is a reasonable treatment options, and certainly maybe the best treatment for men that are older, or men that just want to avoid surgery. It's a great second choice, I think. I think I'm going to stop there because I think it's 6 o'clock, and I'll certainly take some questions.
Tim, this is Chuck. I want to thank you very much for such a complete talk, and we certainly appreciate your efforts to come and talk to us. Mark Kawachi is a friend of the forums also, and he's on the docket for next spring.
Awesome.
He's been very, very good to us as far as seeing our patients and et cetera. I do think I'd like to add to Neil's introduction. Dr. Wilson is clearly one of the best surgeons in the world, and I have worked with Denton Cooley. I scrubbed with him on a couple cases at USC, and Dr. Wilson is even better than that level of surgeon. So I've never been able to say that publicly, Tim, but we certainly appreciate your abilities. Poker wise, maybe not so much.
Oh, thank you, Chuck. I appreciate it.
It's an inside joke. We do have most of our fellows that are on the chat tonight are on active surveillance, or at least a lot of them,
Awesome.
and which has been a really good topic for us, and I appreciate your including it. So we'll let Neil take care of the questions, but I thank you from the bottom of my heart.
Of course, Chuck, it's my pleasure.
Doctor, thank you very much for an outstanding presentation and a few surprises for us that actually surgery stands up to radiation as far as side effects are concerned after surgical effect. I'm going to open this up to questions that you can ask the doctor directly, and particularly those, because we get a lot of them, about surgical procedures to correct impotence and incontinence. We get a lot of questions about what to do next. And I'll mute myself, and whoever wants to jump in.
Sure. So you want me to talk about incontinence and impotence at this point?
Sure, because we're dealing with it with radiation, we're dealing with it with
Of course.
surgery, and we're just dealing with age.
So I think, and so from my point of view, the what I'm going to do, I have a couple. I'm going to breeze through a couple. I have a couple of other slides here that not. So I'm not going to. I have some videos here. I'm not going to show that sort of thing. The for surgery. So obviously, the goal of any treatment for prostate cancer, as I said earlier, is to treat the cancer primarily. That's the primary goal. But number two, and three, and four is to minimize any side effects, whatever those might be. So for instance, that's why active surveillance needs to be. So for instance, we have not only do we offer active surveillance just as we currently do it, and it used to be, as Chuck remembers, when active surveillance first came out, we used to biopsy men every year. And it's still recommended that we do a biopsy within 9 to 12 months of the original to make sure that there hasn't been any progression. I mentioned that we get tests like Decipher to help us decide. And then in addition, we're getting an MRI at 1 year to make sure that there hasn't been progression that way, but we'll then do a second biopsy. But then going forward, there's controversy about this. We're typically just getting PSAs I get them every 4 months now, although I think a lot of people think that 6 months is fine. And we get an MRI every year. And if the PSA is not rising, and if the MRI is not changing, then we don't do a third biopsy unless either one of those two things changes. So my point is that active surveillance is the best way to protect continence and potency. And focal therapy for men that qualify is the second thing. Now, surgery can also protect continence if the surgery is done the right way. So my point here is that you simply want to, if you're thinking about surgery or if you're on active surveillance, something changes and now you need treatment, you need to find a surgeon that is a student of the art. So there's, for instance, my point of this slide is that there are certain things that the surgeon can do. How they spare the nerves is important. We don't have to throw the baby out with the bathwater. So we use a 3D imaging modality called SEVRA, where it's a startup in San Francisco. It takes the MRI of the patient and all the basis of the biopsies, it puts them together in a 3D image. The same way we do focal therapy, in a sense, for men that are having surgery. We know where the lesion is, which is the riskiest. We don't have to take the whole nerve bundle. We might take part of it. Most commonly, we don't have to take any of either side. So my point is, nerve sparing can virtually always be done, even with more advanced or more aggressive cancers. Sparing the tissues around the prostate are all these things. And I'll simply mention that the last thing we've added is what's called, we refer to it as placental allograft. This has to do with the fact that when we take out the prostate, we're creating a wound. And in adults, the nature of wound healing is inflammatory. And so we're creating a wound that has to heal. Inflammation is has a negative impact on the nerves and how they recover. And so a few years ago, this wasn't my idea. We discovered that a guy named Vip Patel, who's we don't just call him Vip, we call him VIP. He's done over 15,000 prostatectomies, but Vip started using something called dehydrated placental allografts, putting them on the nerves after the prostate was out. Bottom line is that it's a better product made by, and I don't have any stock in this company, but I use it routinely, and I've used it in about 700 or 800 men. It has to do with putting a amniotic membrane that's collected from the placenta and the umbilical cord, donated by women, tested to make sure it can't transfer any disease to the patient. We've never seen one problem with it. It raises the cost of the surgery, but not to the patient. Gets wrapped in the insurance bill. It delivers us a compound called, as you can see at the top of this, HCHA pentraxin. It's called heavy chain hyaluronic acid pentraxin 3. And it was discovered because it was noticed during in the 70s in intrauterine surgery, where they're operating on the fetus. That when they operated on the fetus, put the fetus back in the uterus, close the uterus, baby's born, no scar on the fetus. So this compound only occurs in birth tissue. I'm not trying to be wacky here. It's an FDA-approved product for wound healing. So it's nothing mystical. It's just a remarkable thing that decreases inflammation, helps nerve regeneration, and helps wound healing. It actually draws the patient's own stem cells into the wound. We're not putting foreign stem cells in the wound. Anyway, so if you use all those things, it was originally used in the eye. A contact lens called Procara is used for dry eye disease. It's used in diabetic foot ulcers to help wound healing here. And we published some data on it, but it shows that in men where we use it, it shortens the time that to help, as long as I do all those other things I mentioned earlier, compared to controls. Controls are in the red. This product called Amniox, virtually 100% of men are continent. So the best way to treat incontinence is to prevent it to begin with. And so I use it on 100% of men, and especially men that are having a partial nerve sparing, that sort of thing. So anyway, I'll stop. I'll get off my high horse there. This is how, just to show you how it looks, just for orientation. This is the pubic bone here, the rectum down here, the prostate's out. And I got some sutures in here for some reconstruction we're going to do after the prostate's out. And then I'll just show you what this product looks like. So we use it. The biggest problem we have, well, most common reason people don't use it is that they don't know about it, or it increases the cost, and hospitals don't like it. So we're just putting it on the nerves here. We've never seen any infections caused by it. It adds about 2 minutes to the operation. I'm a speaker for the company, but I'm not, I don't own any stock. It's a private company, actually. And there's multiple products like this, but I think this is probably the best one. And then there's another one that comes in, and then I'll move on. So we can, now you're, in terms of, so let me stop that. And it doesn't increase the risk of cancer recurrence. So talking more about incontinence. So if I have someone whose continence has not recovered after prostatectomy, it could be for a variety of reasons. Sometimes it's because of it's complicated. It can become because of bladder instability, so kind of a spastic bladder. Chuck knows this kind of stuff. Maybe it's most commonly stress incontinence. And there's a newer device that we were getting here that's there's a couple of different procedures that can be used for incontinence. If it's, like a male sling for minor stress incontinence works quite well. Of course, there's an older procedure that also works well for more severe incontinence in men after prostatectomy called an artificial urinary sphincter. And there's a new device that we're just getting on that's coming to St. John's here soon that just got approved that I have not used yet. And it involves two balloon-type structures that are placed alongside the urethra to compress the urethra, though it's easier than an artificial urinary sphincter. For men that have incontinence after radiation, it's typically caused by a small bladder that is somewhat, it's been affected by the radiation. It's the bladder somewhat spastic. It could be caused by a scar. So number one, if men are incontinent, they need to have a full evaluation, and it's persistent and it's not after surgery. Certainly a cystoscopy, an evaluation that way to make sure that there's no scarring, to try to understand better how the bladder works. We don't do a lot of incontinence work here. Fortunately, very few of my patients need something. I still send patients that have severe incontinence to my former colleague at City of Hope, Kevin Chan, because he does such a great job. And I know that, I'm no longer affiliated with City of Hope since 2015 when I came over here, but also the guys down at City of Hope, Orange County, closer to you. I think his name is Josh Cohen. He and Jeff Yoshida there, and Josh Cohen does the incontinence work down there. So I tend to refer patients that have incontinence that's difficult to manage to the experts, the guys that do more of it. I'll stop there. God's telling
you don't have to stop. That's mind blowing. That's amazing. Yeah, you don't have to stop. I have a couple of questions, both from our education people. Dr. Metzger, would you like to ask your question about microultrasound?
I just wondered if Tim had any opinion about the upcoming microultrasound and how it may replace MRIs, get it back in the urologist's office.
Yes, Chuck. So in fact, I was just at a meeting in Chicago. It's called Focal 2023, because I was wanting to learn more about this nanoknife technology and other focal therapies, because we've been offering them here, but I've been doing primarily radical prostatectomy. But anyway, so microultrasound is good. Jerry, they had a point counterpoint in Chicago. I can't remember the guy's name from Cleveland Clinic, was talking about, MRI, and Jerry Andriol from WashU in St. Louis. So I think microultrasound certainly is excellent. It doesn't work great for bigger glands. Doesn't work great if there's calcifications. Doesn't work great for anterior lesions. But I agree, the images are remarkable and they're close to MRI, but they're not. It's not as good for staging, So that would be my comment right now, Chuck. But it certainly is a remarkable image, and you can oftentimes see the lesions that are at highest risk. I do think that if you're biopsying men using microultrasound and they do have cancer, ultimately you're going to get an MRI on that gentleman as well, I'm sure.
Very good.
Ira, I know you had some things you wanted to learn more about.
I guess the question is, could you comment on technology to decrease surgical margins such as MRI and PSMA, and also what technology is on the horizon to improve surgeries overall?
Mm-hmm. So in terms of, I'm sorry, I lost my train of thought there for a second. So so can you repeat that, please, Ira? I'm sorry.
Well, first about surgical margins. By the way,
right.
I had the privilege of meeting you back in the day when you were at the City of Hope, and you talked about surgical margins then. But I think since then they have MRIs and PSMA to guide the surgery. So, are those the ones to use, or are there other ones?
Right. So as I tried to show, well, anyway, so one way that we use, surgical margins. So number one, we want to avoid positive surgical margins, but it turns out that they have a positive margin in prostate cancer is not the same as a positive margin in colon cancer, the liver, the breast. It's unique in that way. In fact, there was a study at University of California, San Francisco, done by Peter Carroll, who's years ago, where they did intraoperative margin assessment. In other words, they did the prostatectomy, had the pathologist look at it, and if the margin was positive, then they resected the tissue, the entire nerve bundle on that opposite side, and in fact, in that particular study, I think it was 100 patients, they found no residual cancer in the residual tissue they took out. So furthermore, even if there is a positive margin after a prostatectomy, it has minimal impact on recurrence. It does have there's some studies that show it has no impact. And so that we want to avoid them. It makes patients nervous, makes the surgeon nervous. It probably increases the risk of recurrence about 5%. But we now know that if there is a positive margin, based on recent studies, there's a recent randomized trial published 2 or 3 years ago now, showing that even in the setting of positive margins, monitoring those men and not giving them radiation as we used to after surgery is equally effective. We can wait and just monitor the PSA because the majority of those men will not have their PSA go up again. Now, so I'm not saying that we should ignore positive margins because it does increase the risk probably a little bit. But what I use is a technology I alluded to earlier called SEVRA. So this is, I can try to pull up to you. This is cool. So the patient doesn't pay for this. It's a startup in San Francisco. Intuitive Surgical, the robot company, has a similar technology that they're developing. What they use is the patient's MRI, and I don't know why this there we go. And okay, so can you see this that I'm showing here?
Mhm.
Prostate. It's
Right.
here a little bit. Anyway, so basically it's a 3D image of the prostate. The kind of the orange nodules, the gold here is the neurovascular bundles. The gold is the cancer in the prostate. And so I can use that as a roadmap during surgery to guide me as to how close I can be to the nerve bundles. It's just an example of the kind of technology that's becoming available.
By the way, when I met you back, it was probably about 10 or 11 years ago. I went with a friend of mine, and I think you mentioned at that time your surgical margin was, I think, 16 or 18. So I bet it's reduced by a lot now.
Actually, it's high. It's higher. And this is common in all academic centers because we're trying to be close to the prostate, but it's primarily higher, Ira, because we're operating in higher risk men. So back when I met you, we were operating on a lot of men that still we continue to learn that were candidates for active surveillance and didn't need aggressive treatment. Now, now we operate, or now we treat a lot of guys with active surveillance. We treat a lot of guys with focal therapy. We treat a lot of guys with the guys who get surgery are typically higher risk, have bilateral disease, and they're still interested in nerve sparing, and so it's anyway. So they're higher risk. So it's probably the positive margin rates across the nation, even in high volume surgeons, are probably somewhere in the neighborhood of 25-30%. But the blessing is we know we don't have to treat those men. We just monitor them.
Excellent. And are there other technologies on the horizon other than that you want to mention?
Well, there's a guy named Martin Greffen in Hamburg that developed a technique for examining the prostate right after surgery, kind of similar to what I alluded to earlier at UCSF, where they take the prostate out, they analyze it, and if there's a positive margin at that time, they go back and take out more tissue. So, but now PSMA is not as anatomic as MRI. MRI is is a more detailed, and it's still not perfect. So, but PSMA is the best staging modality, but it has kind of a bloom to it, or a glow. So it's not great for looking at, for predicting margins. It can tell us if there's cancer that we may have missed on one side that we didn't see, that where the biopsies, we think it's negative on the left, we get the PSMA and it shows it on both sides, for instance. So it's not perfect, but it's a good test. We're still learning a lot about it.
Okay. Thank you for the complete answer and for the the wonderful presentation you made. Thank you very much.
You're welcome.
I'll open up the floor again to any other questions, comments, suggestions. Anybody?
Yeah. Hi, Dr.
Hey, there's
Wilson.
Bob.
Hi. Just a quick comment. You mentioned that PSA screening really en masse only started in the 1990s. Did I hear that right?
Yeah.
I didn't realize, maybe I've heard it before, but I thought PSA screening's been around forever, but apparently it hasn't.
No, it was the solution and the problem at the same time. So Chuck remembers those large screenings we used to have, mass screenings at up and down the San Gabriel Valley. When I lived in Glendora, then Claremont. He lived in Glendora before he went down south. Yeah, so about in 1991, 1992, mass screenings for prostate cancer began.
Okay. So put it in perspective. So when I started screening in the 2000, late 1998, 2000-ish, it hadn't been around that long.
True. We were still learning a lot about it.
Okay, interesting. Now I'm on the edge with PSMA PET CT for recurrence. So, I mean, I'm right on the edge there.
Yeah, so there's a lot known about that. So yeah, so I mean and we're always learning. There's been a lot of advancements, but we're learning all the time about how best to do things. If you guys don't mind, I think I'm going to sign off. I'm worn out, and I.
And you may have work tomorrow.
Yeah.
You may have surgery bright and early.
Maybe this was worse than a surgery. Who knows?
I'm taking out a bladder tomorrow, so there we go.
You got to be rested. Doctor, thank you so very much.
Ew.
We'll let you, when we look forward to talking to you again soon. Outstanding presentation.
Great talk.
I'm going to suggest for the folks at home,
Hey, thank you,
watching on
doctor.
YouTube in another few weeks, please check out our website at prostateforum.org. Prostate Forum is one word.org. We are a nonprofit organization serving all of Southern California, but if you're not in Southern California, drop us a line anyway at prostateforumoc@gmail.org, and we will try to help you with some of your needs if we can. And by all means, check out our YouTube channel. You can see our presentations on our prostateforum.org website. We also look forward to any financial help you can give us. We are now taking vehicle donations, and you'll find that at our Support Us section of our prostateforum.org website. Meantime, I wish you a wonderful Thanksgiving, and look forward to seeing you again in presentations in January. Have yourself a great evening. We look forward to seeing you again in presentations in January.
Yeah, come to Orange County, Tim. I'll take you to dinner.
Good seeing you. Hey,
Okay,
thank you,
Chuck.
Dr. Wilson.
Yeah, you're welcome. Hey, Chuck, have Kawachi call me. I haven't heard from him.
Okay.
Okay, bye. Talk to you later. Bye.
Bye, everybody.